The advent of toric IOL has revolutionized our ability to improve refractive outcomes and patient satisfaction after cataract surgery. Although recommended only for the correction of regular astigmatism, it has been used successfully in cases of irregular astigmatism such as in keratoconus. The treatment of any astigmatism would be considerably simpler if refractive and corneal astigmatism coincided in magnitude and axis. Variance between manifest or wavefront refraction and keratometry or topography is widely prevalent, however, and the consequence is that the surgeon must rely on his clinical judgment to treat astigmatism and still have to pick a number, not to mention when keratoconus coexists with cataract. In this video, we will present a case report where strategies to address irregular astigmatism correction were used on a keratoconus patient with cataract. The patient is a 63-year-old white female who presented complaining of decreased visual acuity on her right eye for the past 2 years. CDVA was 2.00 logmar with the refraction on the screen. On the left eye, CDVA was 0.10 logmar with a refraction of -3 sphere, -half diopter cylinder axis 180. Past medical history was significant for a history of keratoconus diagnosed in her early childhood, more severe on the right eye. She has never wore contact lenses. Ocular examination was remarkable for a N02 C3 cataract, LOX 3 classification, and a stage 2 keratoconus on Alliot classification on her right eye, and stage 1 on the left. The left eye displayed a C2 cataract. The remainder of the examination was within normal limits. Autorefraction and keratometry showed here display a 7.75 cylinder of astigmatism on the right eye, the steepest meridian at 116 degrees. Placido disc-based topography displayed here show an asymmetric bow tie with inferior steepening and a 5.27 cylinder with the steepest meridian at 115 degrees. IOL master keratometry displayed a reading of 41.1 at 29 degrees and 49.85 at 119 degrees. For a target refraction of planar sphere and using the IOL master's K readings, the company's online calculator displayed the table shown here, proposing a 14 diopter sphere and a 6 diopter cylinder, leaving more than 2 diopters of a residual cylinder. The IOL power calculated for emmetropy by the IOL master was 15 diopters for a spherical IOL. Wavefront aberrometry was not feasible. The surgical plan included the placement of the corneal incision on the steepest 115 degrees meridian, based on the topography to enhance the cylinder correction, and go with the 14 diopter IOL since there would be a -3.4 diopter of residual cylinder. The patient underwent an eventual phakic emulsification with implantation of a 14 diopter sphere and a 6 diopter cylinder Rainier's toric spherical IOL model 623T. Preoperative and 30th day postoperative dilated retroillumination photos shown here confirmed axis placement at approximately 115 degrees using the Adobe Acrobat software. CDVA was 0.18 logmar with the refraction displayed here. Orbiscan examination shown here on the 30th day postoperatively displayed a SIM case of 6.9 diopters, a decrease of about 1 diopter from preoperative measurement, with the steepest axis at 113 degrees. The patient stated she has never seen that well in her whole life. The use of toric IOL on keratoconus has been advocated by one of the pioneers on the field, Dr. James Gills, who states that patients see surprisingly well with torics because when a clear zone of visual acuity is created, the brain is able to pass through the distorted areas that are caused by the extreme flat and steep zones in the peripheral cornea. To Dr. Gills, one of the most challenging aspects of surgically treating keratoconus patients is identifying the correct axis for IOL alignment as well as incision placement. He relies on the surgical keratometer to identify the steepest meridian within the central 3 mm optical zone, which impacts the patient's functional vision. He claims that treating astigmatism in patients with keratoconus is perhaps more art than science. Keratoconus, due to the corneal bulging, causes severe optical aberrations like coma and more negative spherical aberration. These aberrations have a significant impact on vision, especially loss of CDVA and contrast sensitivity. Spherical IOLs which have positive spherical aberration should be the wise choice due to the increased negative spherical aberration of the ectatic and significant prolate cornea. The use of toric IOLs in patients with stable cone and reproducible astigmatism in all meridians, as it is in our case, axis and amount of astigmatism are consistent on all the instruments, is becoming the gold standard. It is a hot topic on our society web forum. Regarding the IOL power, there is a tendency to target toward a myopic outcome, or they will end up hyperopic. These patients have an altered Gauss-Strand ratio, so there is a need to put a high power IOL than you planned for. The amount of fudging is based on the amount of steepening they have. The power of the toric would be determined by the case. Some authors usually consider manual keratometry to work best, and try to be conservative, correcting astigmatism, because even somewhat undercorrected, these patients do well. Irregular astigmatism patterns and determining the axis of astigmatism still remain the two biggest challenges when dealing with toric IOLs, because no single instrument will give the right answer all the time. This case and many more presented lately in the literature and in meetings have shown that toric IOLs are effective for the surgical correction of irregular astigmatism in keratoconus patients, but we, as surgeons, must keep striving to solve the case puzzle. Thank you very much for your kind attention.